then we start recording now.
That's fine. So I assume this is a lecture of the normal program of their classes, right?
Yeah. So now it's for the minor global health then, of course, but for the third year students, like you did before earlier on, also with Trudy.
Mm-hmm.
She's still in the program. She was lecturing Monday. So yeah, but of course, normally students would have been abroad already this week. So we only had a program for 5 weeks in Rotterdam, and now we have a full program of 10 weeks in Rotterdam because of Corona. So the electives abroad have been moved to summer 21. So we hope a vaccine will be available then.
Well, let's cross our fingers. I mean, that's quite optimistic, but let's see how things go.
Yeah, true. If it's after Trump, then there will be a vaccine, of course, beginning of November.
Yes, definitely. The Russian one is ready now.
Yeah.
It's already approved. Putin put it on, so ready to roll it. But we'll see. We'll see what happens.
Exactly. Okay. Shall we just start, Oscar? Because it's 10:03.
Yeah, feel free, Jan. I'll follow your lead.
Okay, so good morning, everyone. There were some changes in the program. Luckily, Professor Oscar Franco Duran was able to move his lecture from next Tuesday to today. Not sure if you know Professor Oscar Franco Duran. He's originally from Colombia, and then moved to the UK, spent a couple of years over there, and then moved to Rotterdam, Erasmus Medical Center, and was for some time also director of NIES, wasn't it, Oscar?
Yep.
Yeah. And now since a couple of years ago, he moved to Switzerland, but as you all heard, he's now in Leiden because his wife doesn't like the mountains, but so he has to travel up and down. And I saw Oscar posting, so he has been lecturing in the minor global health before, and I saw on Facebook some posts about COVID-19 and indigenous Indian populations in South America. So I thought it would be a good idea to invite him to lecture on COVID-19 in indigenous populations. We changed the topic a little bit about the history of a pandemic, and there will be a focus on lower middle income countries and also on some on indigenous populations, but mostly on the history of this pandemic. So Oscar, floor is yours.
Thanks a lot, Jan, and good morning, everyone. I hope you're all comfortable with your cup of tea and in your pajamas. Following the lecture, we'll try to make it interactive as much as possible. I don't know how you feel about talking all the time or looking all the time to screens. But once in a while, I will probably call one of you and ask you a question. You don't have to turn on the camera if you feel uncomfortable, if you don't want to be seen. But I will see, I would like you to participate interactively. We have 2 hours, as I understand, and this is the minor on global health. And we're going to talk about a topic that is very important for global health, and we're going to try to take a global perspective. Originally, Jan asked me to prepare a lecture about indigenous populations, but the truth is also indigenous populations are perhaps the population at the biggest risk of suffering from this pandemic. There is no data. There's almost no data on this population. Nobody really cares. So we are going to go through maybe a historical perspective into the pandemic. We are going to talk as well about the next steps that could be taken within the pandemic. And I'm going to tell you also a little bit about my personal history, how I got into the pandemic. So far, this is my publications until now, and the majority of the science and the work that I have done has focused on cardiovascular disease prevention, on healthy aging, but not on infectious diseases. I never liked infectious diseases, to be honest. I trained in medicine, and this was my least favorite topic. In fact, of these 700 publications by the beginning of March, I only had 4 that had something related to my talking to you about COVID-19 today. That's what we're going to be talking about today. As I mentioned, we are going to try to have this a little bit relaxed, informal, and very interactive, and I hope you join me. Let's start talking about history, and not just about myself and the pandemic, but history in general. And you probably know this painting is called the Mona Lisa or La Gioconda, and it was painted between 1502 and 1506. Some people think between 1503 and 1520. It's not very clear the history of the Mona Lisa, but Leonardo da Vinci, one of the greatest genius ever, and one of the persons I admire the most, painted the Mona Lisa. But have you ever wondered, have you ever sat to think, how would the Mona Lisa look like if Leonardo da Vinci or the Mona Lisa would have been exposed to the 21st century? And I think that perhaps she would look like this, maybe like this, or perhaps like this. When I tell this story, people tend to try to destroy my story and say, well, if Leonardo da Vinci would have been in the 21st century, would have not painted this lady, but would have painted someone more of a celebrity of the time, and it would look like this. Or would have painted someone in the audience and would look like this, or maybe a leader and look like this, or in the time of pandemic, it actually should look like this. The situation is the circumstances have changed dramatically, but there are some things that remain. Let's start with the fact that the Mona Lisa serves us to put a framework around one of the greatest successes in humankind history, and that has been the decrease in mortality and the increase in survival and life expectancy. Life expectancy is the amount of years that on average can live a population from a certain age. Normally we looked at it from birth. And as we can see here, in the last 150 years, we have seen an increase of 45 years of life expectancy, which means that for every week you live, you gain a weekend. For the 2 hours we're going to talk, you're probably going to gain something between 30 and 40 minutes. If you fall asleep, you gain more because sleep is good for your health. So what we see here is that in the future, we could even have populations living more than 100 years on average. Is that true? Could that be possible, and could that continue? What we have seen is that it has been basically a linear, a smooth increase in life expectancy, except for a big gap here. Does anyone in the audience wants to tell me what happened here? I'll ask Annika. I don't know if you can hear me.
I think the World War, but I don't know.
Okay, Annika says the World War. What do you think, Anouk? Do we have many Anouks, but any Anouk that wants to give an opinion, please.
Maybe the Spanish flu?
Yep, that's the Spanish flu. La gripe española, or the Spanish flu. Thank you, Anouk. Thank you, Annika. So the Spanish flu basically was called Spanish because it was first portrayed in the newspapers in Spain. In fact, the first news came out at the 22nd of May, 1918. And the reason why the newspapers in Spain gave the news about the Spanish flu were because we were in the middle of the First World War. The First World War was happening already, and many countries that were involved did not want to destroy the morale of the people and of the soldiers. So they didn't want to put it in the newspapers. So the censorship of media is something that is not new, as you can see. So in that time, Spain was not part of the conflict. They were neutral, and they decided to publish the news about the epidemic that was in that time hitting Madrid. Here you can see the ones that speak Spanish say here, "Esem el rey enfermo, su majestad el rey está enfermo." Basically means that the king also got a Spanish flu. We can see here many of the newspapers in that time, also special bulletins from the government where they were invited people to get aire libre, agua y luz, basically that they should be in open air, they should let light coming into their houses and use water to wash their hands. This is something that has been happening also during this pandemic. When we look at pictures from the Spanish flu pandemic, this is normally the pictures that we see. So young people in what we see very big hospitals that have been reconditioned to help these people. And this is what in that time was the new normality. I don't know whether you like this special mask, but they look quite nice to me. to my opinion. This is also how sports were affected. This is a baseball game. This is New York. This is the Red Sox actually. And you can see the people in the public wearing a face mask, and also the player and the umpire and the catcher. So anyway, the Spanish flu did not start in Spain. It actually started in Kansas. That's what people think. What is clear is that when we trace this virus, it came from North America. And people think that it started here in Fort Riley in Kansas. This is a picture from 1917, when the first cases of Spanish flu were detected. There were cases of pneumonia in the soldiers that were being trained. This was a special place where doctors were being trained to go to the First World War. America joined the First World War later in 1918, during the last year of the conflict. And we can see here how the soldiers were then sent to the frontiers of the war, which was in this time the fields of Flanders and France. And they came in March 1918. They gave it to the Allies, then they gave it to the enemies. And then in the second part of 1918, the virus was spread throughout the rest of the world. We saw a wave or not with the current pandemic. And the 4 waves that we saw the first was in the spring of 1918. That was first, as I said, described by the Spanish media. Then in autumn of 1918, this was the one that killed the most people. Then in spring of 1919, and the last outbreak happened in 1920. Afterwards, this pandemic disappeared. And that's probably why you heard some leaders in some countries saying, don't worry about coronavirus, it's going to disappear. So the Spanish flu, as I mentioned, circulated thanks to a conflict. It was the First World War that was happening. The soldiers brought it to their enemies, to their allies, and then distributed. It also shaped how that conflict ended. The First World War ended in 1918, at the end of 1918. And you can see here the prime ministers of the UK, Italy, France, and the US. And we see David Lloyd George, the prime minister of the UK. In 1918, he was age 55. He went to Manchester at the end of November to celebrate in a parade the victory, the armistice that had been reached with the enemies, with the German and the allies of the Germans. He went to Manchester to celebrate, and he got the Spanish flu then in Manchester. But the picture that we can see here is in the spring of 1919, when the Treaty of Versailles was signed. But basically, they had the peace treaty and the terms that were put under for those that lost the war. And you can see here Georges Clemenceau, who was the French prime minister, who was very unhappy with the Germans and wanted to have very strict conditions against their enemy for all the history of conflict that had happened before against Germany. And here you can see Woodrow Wilson, that was the president of the United States of America, who was not very keen on having very strong measures against the Germans until he got Spanish flu. So he got some neurological symptoms, and then people thought that President Wilson had a stroke. But seems to have happened is that he got a neurological complication of influenza that clouded his judgment and allowed him to accept all the conditions that Clemenceau were posing, and the Treaty of Versailles was signed. And we know what happened afterwards. So those that don't know, basically this treaty put very bad conditions against the Germans, and then the Germans didn't like it, and then the Second World War happened. So many people say that the Spanish flu was distributed by the First World War, ended the First World War, but created the Second World War. In total, Spanish flu affected approximately 50 to 60% of the population in the world. The population at that time, that was 1.8 billion people. Of these people that got infected, 1 to 2% died. That means that approximately between 40 and 100 million people died. This is equivalent to the combined number of fatalities that occurred between the First World War and the Second World War. Nevertheless, it is very little the information that is provided to children or to people in general in their education about this situation that was the Spanish flu, the biggest pandemic ever in history. But let's look at history of influenza. Where does it come from? The first epidemic of influenza was recorded in 1173. In 1493, America was discovered, was in 12 October 1492, and in 1493, in the fourth trip of Christophorus Columbus that was being funded by the Spanish crown, they brought some pigs that brought with them influenza and brought it to the indigenous populations. It is believed that killed approximately 25% of the natives in America. Then we see here in 1510, there was a big epidemic in Florence, in Italy, in Firenze, where for the first time they called this back influenza, which means the influence, because they thought it was the influence of the planets or of the gods. Then we see here in 1918, the Spanish flu. And then what we see is that the H1N1 type of influenza disappeared around 1933. It was replaced by others, and then it reappeared in 1977. So it was very weird because suddenly there was a re-emergence of H1N1, and there was a big pandemic that started between Russia and China and spread to the rest of the world in 1977. And what was weird was that the virus was exactly the same as the virus in 1928. So it seems that there will be an accidental release of a frozen sample that was kept in a lab. It's not very clear if it was China or Russia, but a sample that was in a lab actually was released accidentally. We never know how samples are released, and it came into the general public. Then we had in 2009, the last big pandemic of H1N1, because it came back in 1977 and stayed with us. And that was the swine flu pandemic. Maybe some of you heard of that. There was a lot of panic regarding this pandemic because we thought it was the new pandemic of a Spanish flu like it happened in 1918. However, it did not have the impact as we thought. This was also called Mexican flu because it started in some of the farms of poultry, of chicken in the northern part of Mexico. So, and as you probably heard recently, I don't know if you heard of this or not, there is a new type of H1N1 or avian-like swine influenza virus, which has a potential to become a pandemic. This was in the news earlier on in April and in May, where they were talking that there could be a new type of swine flu. And basically, in China, it was detected after 10 years of observations in a lot of pigs in different farms in China. It was detected this new type, which is called G4EA. G4 is the genotype 4EA, is Euro-Asian H1N1 virus. So it has a little bit of the Euro-Asian type of influenza. It has H1N1 because the virus that caused the Mexican flu in 2009 went back to the pigs. And so it has part of that virus as well. It has part also the virus that caused the Spanish flu. And we have seen that already some of the workers of these farms had the infection. It's not clear where they had clinical symptoms or not. There are 6 clinical cases that have been confirmed to have been infected, but so far this virus is not transmitting from human to human. But basically the message here is that when we talk about pandemics, and pandemics are, it comes from the Greek pan, is everyone, and demos is people. We refer normally to pandemics with 2 epidemics. So this is a spread of diseases that happens throughout the globe, normally affecting more than 2 continents. When we talk about pandemics, the biggest fear we have is something caused by maybe swine flu or avian flu, but in general, it's influenza that we fear the most. However, if we look at the history of the pandemics, the biggest pandemic, yes, that we had was a Spanish flu that you can see here. Then the Black Death, but this was not caused by influenza, it was the bubonic plague. And we have the plague of Justiniano, that Justinian was in the time of the Roman Empire. These are the 3 biggest pandemics that we had. In the last decade, we thought, when is the next one going to arrive? We know HIV happened in the 80s, and it has killed more than 32 million people. But afterwards, we have swine flu in 2009, we had SARS in 2002, that was a type of coronavirus, MERS by another type of coronavirus, and we had Ebola in 2014, but they never became as big as Spanish flu or any of these big pandemics. And the question was always, when is it gonna happen and where is it gonna happen? And so the story takes us to the city of Wuhan. The city of Wuhan is 11 million people. And this is Li Wenliang. I don't know if you heard the story of him, but basically on the 30th of December, he sends, you probably use WhatsApp, or it's a way to send chats to people, but he sent a chat either using WeChat, which is like the WhatsApp in China. And he write, "Hi everyone, my friends in infectious disease told me not to go to the Huanan seafood market. There has been a cluster of unknown pneumonia similar to SARS. Today we admitted multiple patients from Huanan seafood market. Everyone make sure wear masks and get good air circulation." This was 30th December of 2019. He was communicating this to a group of friends in their WeChat, and this message became viral. It came to the ears of the government of China, and he was censored and he was told not to talk anymore about it. This is a map of the city of Wuhan. As you can see here, it's a city of 11 million people divided by one of the biggest rivers in the world, the Yangtze-Kiang, the Yellow River. And you can see here where the hospital where Li Wenliang worked. He's an ophthalmologist. He was an ophthalmologist. Here is the hospital where he was working. Here is the Huanan seafood market that he was referring to in WeChat. And here is a railway station that is very big, that is called Hankou Railway Station. And what we see here is, this is a picture of the railway station from outside. This is a picture of the railway station from inside. And as you can see, very crowded. And as you can see here, the distance between these two places is 15, 20 minutes walking. Between the hospital and the seafood market is sort of 5, 10 minutes walking. So people normally circulate in the station. When they come out of the station, it's quite often possible that they drop by the Huanan seafood market. This is the Huanan seafood market, where you can buy food to take, but also to eat. It's a little bit, you know the markets, how they work. But basically, it's not just about seafood market. You can basically buy any single animal or any possible animal that you can find. And quite early in the pandemic came out the story that the closest ancestor to this coronavirus, once it was identified, came from bats. And the theory was that in the Huanan seafood market, they had bats where they can eat them as soups or where they can purchase it and eat them. And they had bats there and they were in close contact with other animals. And the theory then was that maybe it went from the bat to a pangolin. This is a pangolin who is also consumed, and it was also stored in this market. And maybe it went from the bat to the pangolin, and the pangolin it adapted further, and then it jumped from the pangolin to the human being. However, they took 330 samples in the Huanan seafood market, and none of the samples in animals came positive. Only samples in places, in utensils or on tables. So that the Huanan seafood market is the origin of the virus is a theory that is practically no longer in place. What is most likely is the Huanan seafood market was just a place where there was a super spread event. Basically, the virus went to many people because there is a lot of people coming to this market that is very big. So where did it start? Further information was found that approximately 8 years before, there was a reported cases of pneumonia that led to intensive care unit treatment and then led to mortality. Here we have Wuhan, and basically they call the investigators from the Wuhan Institute of Virology, which I'm going to show you where it's located. Here is Wuhan's Institute of Virology. And the investigators from the Wuhan Institute of Virology were invited to come and investigate what was happening. They took samples, they sent them to Wuhan, they stored them. And in 2016, they published a paper in which they reported the genome sequence of a new coronavirus that they thought was dangerous. This was exactly the same one that was reported in February of this year as the closest ancestor to the current coronavirus that we are seeing. So it's very likely that the origin of the virus is is definitely not in the market. It's very likely that the virus probably came or was circulating through China or through the world far earlier than expected or than believed. Or there are also theories that maybe there was a lab accident. We don't have evidence to prove or to deny any of these potential sources of the virus. When we talk about the origin of the virus, some experts say it's almost impossible to create such a virus in a lab. However, we know that there are experiments in which different types of viruses are combined in order to look at how the viruses might behave or how they could be utilized as a vehicle for a vaccination. So we knew that there were some experiments being done in this lab, and there were some concerns about the safety. So by no means I'm telling you today that it came out of a lab, but so far what we don't know is where the virus comes from. So what happened then in Wuhan? And this was very nicely summarized by a former student, Ampan, who is a close friend and is a professor in Wuhan, and he was the first person who told me about the situation early in January this year. So this is basically what happened in Wuhan, and it is divided in 5 phases. The first phases are the early stage where there were no strong interventions, and this was in December. The first case was detected or was confirmed, had symptoms by the end of November, and on the beginning of December was confirmed. This person and 30% of these early cases had no contact whatsoever with the seafood market. Another reason not to think that the Huanan seafood market was the origin of the virus. So what we see here is the first cases started to happen. There was this December 30, the notification from Li Wenliang to his friends about there are some cases of a weird pneumonia that seems like SARS, but it's not SARS. So be careful with the Huanan seafood market. And during this period of time, nothing was done. Only until the 30th of December, China communicated the cases of pneumonia and that it was not very clear what was the origin. However, there is also reports about people that went to the Olympics of military forces that took place between the 18th and 27th of October in Wuhan. And some of the athletes that went to these Olympics came back complaining that they had some respiratory symptoms or they were sick during the time of the Olympics in Wuhan. And they were complaining that perhaps they had had COVID-19 even before. There were reports from athletes in France, in Spain. However, this has not been investigated further. Also came a paper from the group of Harvard School of Public Health that mentioned that by looking at satellite images, they could see that the amount of cars being parked in hospitals increased dramatically from September onwards, suggesting that perhaps this pandemic or this epidemic started earlier than it was communicated. But this is still speculations and we don't know yet. So this was the first phase officially. And then what we see here, finally, the 30th of December, when this communicated to the world, there is some kind of weird pneumonias. We don't know where they're from. Li Wenliang, as I told you, was suspended from his work for telling these things in WeChat and created panic. That was the reason. And he then came back to work on the 2nd of January. And the 2nd of January, as an ophthalmologist, he was seeing some patients. He had a contact with a patient that was an owner of a stall in the Wuhan market, and he got infected with coronavirus. He was age 33. The second phase is a phase that is called during the time of the Chunjun migration. I don't know if you have heard about this, but the Chunjun period is the biggest migration that happens in every year in the planet. Basically, it's around the Chinese New Year. You know, they celebrate the New Year in a different calendar. They don't use the same calendar that we use. And the Chunjun period occurs approximately some 15 days and 20 days after the New Year in China. And here, a lot of people travel back to their homes, or they travel around the world, or they go somewhere to visit their families and celebrate the New Year. And it is here on January 6th when I first heard about the pandemic. That was my birthday, and I had a conversation with my friend, with Ampan, author of this paper. and he was telling me things are not that great. There is something going on and we don't know what it is. The new year in China, as I said, was January 25, and it was the year of the rat. And during this period, during the Chunjun period, what we see is a lot of people traveling. And Wuhan is right at the heart of the rail connections in China. They have a very good network of very fast trains. And you can see Wuhan here between Shanghai, Beijing, Hong Kong, and Chengdu. So a lot of people take the train and travel around. And in this year, there were 80% approximately compared to the previous year because of what happened afterwards. There was a total of 1,400 billion trips happening in China. They were through train, through buses, through planes, and approximately in the period that happened before the Chinese New Year, some 4 to 5 million Chinese flew outside China. By this time, we already started to understand, or we were already being told that this was a bug that was called coronavirus. It was from a type of a subfamily, that's the beta coronavirus, and it was very similar to other coronavirus such as the SARS. The coronavirus that called SARS is approximately 80% similar. It was also from the same family of the MERS coronavirus, that's beta coronavirus. There is also the alpha coronaviruses and the gamma and the delta. The gamma and delta only affect animals. By that time, also we started to understand how the virus will get into the cells, and it was clear that the virus will use a receptor that was the receptor of ACE2, which is normally an important component that we utilize to treat hypertension. As you know, we have inhibitors of these receptors or blockers of these receptors. And this is how my interest started to get into the coronavirus and the pandemic, also scientifically, because as you know, I work, as I mentioned earlier, I work on cardiovascular disease prevention. So I was concerned what will happen with cardiovascular disease patients and antihypertensives and people with high blood pressure. Should they actually stop taking their treatment? And we saw that actually in this paper that became infamous afterwards because it was this is the Lancet paper that was retracted that suggested that hydroxychloroquine was negative, was not good for you. But in this paper basically was the first also to show that ACE inhibitors and angiotensin receptor blocker did not have an effect on mortality in patients. So basically, what we have found afterwards and during this process is that patients that take this type of medications are not at a higher risk. So then what happened afterwards? Then came by January 23, and seeing that the cases were increasing with the Chunjun period without the strong interventions, the government decided to put the Wuhan area and the whole province of Hubei under what is called a cordon sanitaire. Basically, you lock a specific geographical area. This was a very difficult decision because it was just before the new year. So they took this decision, they put the city on lockdown, they suspended all traffic, and then sent everyone to have quarantine at home, being concerned of what could be the consequences of this. By this time, the 30th of January, the WHO declared this situation as a global emergency. The 31st of January, the USA restricted flights, and there was the first cases in Italy reported. 2 tourists came on mid of January to Milan, they went to Rome, and the 31st of January, they were tested positive for SARS-CoV-2. This is a normal street in Wuhan, and after this lockdown was imposed, this is how the streets look. As you can see here, there is a lot of high-rise buildings. A lot of people live in very small apartments. And when they were sent to have quarantine at home, well, it was clear that they were going to be in closed spaces, and therefore transmission between families skyrocketed. So basically, people were too close to each other, and therefore the transmission occurred even higher. So what they did was they tried to come up with a solution so that people will not infect each other, family members in the residence. And they did something that it was called centralized quarantine. And centralized quarantine is basically people that had contact, that had symptoms, or that had suspicion will be removed from their homes and they will be put in other places. But first they have to create the places. So Also around this time, the first death from SARS-CoV-2 happened. This was in the Philippines. That was the 2nd of February. And the 7th of February, Li Wenlian died from coronavirus. Many pictures were coming around this time, and we saw a picture in which we could see fields and a lot of machines that were digging, and we thought they were constructing mass graves. But what they were building were huge hospitals. And what they did, they created 2 hospitals within a week, within 10 days. It was 2 hospitals, the Fire God Mountain and the Thunder God Mountain, one hospital for 1,000 beds and the other one 1,600 beds in a record time. But besides this, they had already a network of hospitals. So there were a lot of hospitals throughout the city of Wuhan. But besides this, they created a new concept that was called the Fangan hospitals. Fangan sounds like the Ark of Noah. You probably heard of the Ark of Noah history, where there was a big flood and an old man in a big boat brought different species and animals to preserve them, because there was a lot of people that died in the world a long time ago. So basically, these hospitals were called Ark hospitals. They were either stadiums or auditoriums that were converted into hospitals or hospices, basically, because here they will isolate patients and with mild symptoms or family members. And the idea was to have here, there is a medical team that you can see here. So there will be medical care, they will be provided with shelter, they will be provided with food. And there was also a lot of social activities to try to maintain the mental well-being. So this was central to be able to have a centralized quarantine, because if you are going to remove people from their houses, you need to be able to put them somewhere. So during this period of time, centralized quarantine and treatment, we have the 2 specialized hospitals, the overall network, and people were taken if they had close contacts or they have any symptoms or they were presumptive or they were confirmed. A lot of tests were done as well. And then the 5th phase was the centralized quarantine plus a community universal symptom survey. They basically went home by home to check if people were having symptoms. And this took place in 3 days. Just remember, the city of Wuhan is 11 million people. So you can imagine the huge effort to be able to count these people. During this time, 11th of February, COVID-19 was declared as a disease, and it was called COVID-19, and the virus was called SARS-CoV-2 because it was so similar to the previous coronavirus that called SARS. And the 23rd of February, we see that Italy and Iran start to increase a lot in their cases, and the first case starts to being detected in Latin America, which was a traveler coming from Italy, coming from Rome, flying through Spain and going to Sao Paulo. This is, you probably heard the R, reproductive number. And the reproductive number is basically, I call it the speed of transmission. And if you have 1, basically you have controlled the epidemic. If it's below 1, the epidemic is going to be disappearing. But if you have above 1, basically 1 person can pass it to a large amount of people. At the beginning of these phases, and I will tell you a little bit more about it later, at the beginning of these phases, we see a speed of contagion that approximately was close to 4. During the massive migration or the Chunjun period was between 3 and 4. And then you can see here the immediate drop when there is a city lockdown and traffic suspension. And it comes then when they had the centralized quarantine and when they had built the hospitals and they had brought 30,000 personal healthcare personnel from the rest of China, we can see here how the speed of transmission is below 1. Then they had the Universal Symptom Survey, and then by mid-March approximately, Wuhan declared victory over the epidemic that was taking place in Wuhan. A lot of things we learned from Wuhan, and we talk about the R, the speed of transmission. And we understood now that if a person had the disease, he could infect within 5 days approximately 2.5 people. This is an R of 2.5. That will mean that in 30 days, that person will infect 406 people. But if you decrease the exposure, if you halve that R, that transmission, and instead of 2.5, that person could infect 1.25, then in 30 days, you can have 15 people infected. So it was very clear that it was important to have social distancing. As we can see here, what happens if we don't have social distancing, what happens if we have social distancing, and how if we don't implement measures of social distancing, then the healthcare system will basically collapse. We learned more things. We also saw how in China, while at the end of February, the epidemic was being controlled, as you can see here in this flat line, then Spain and Italy took over basically, and the infection skyrocketed and collapsed the healthcare systems in these countries. Finally, on the 11th of March, the WHO declared this situation as a pandemic. And it is around this time when the 11th of March, I had lunch with someone in Bern, and then I came to the Netherlands, and this person called me the following day that this person was positive for COVID-19. So I isolated myself in my attic. This is my attic. So I showed you a picture where I spent 14 days. And during this period of time, I had, well, a lot of solitude, but I was fine. It's not bad. I have television, toilet, everything. So I was fine. But I started being concerned a lot about what would happen with Latin America and with developing countries. There was a lot being said about what was happening in Italy, in Spain, in the Netherlands, in Europe, in Asia, but there was not a lot of communication about what could happen to low and middle income countries. And as a Colombian, I was very concerned about Latin American people specifically. So I remember arriving that night to Leiden, and I remember the following day being there in this place where in my attic. And I started looking into social media and into what was being communicated. And I could see that there was a lot of communication and a lot of information coming out in English and in Dutch, but not in Spanish. And the majority of people in Latin America do not speak Spanish. So what they will hear was a lot of rubbish, to be honest. So there will be all kind of messages that if you drink the pee of someone in the morning, you will be cured. Or if you may drink a cocktail of 3 aspirins with lemon, that will be the cure for coronavirus. So we have a lot of people with gastritis. So I got very concerned about the situation. I started posting on Facebook. And then there was a channel, a television channel that is called France 24, that is the national television channel in France. They asked me to join as a scientific advisor. And then I started having a program there in France 24 that was every day for a number of minutes. It was 5 minutes. We will talk about different things regarding the coronavirus. So I went from not liking at all infectious diseases to being confronted with the worst nightmare for an epidemiologist, which is a pandemic like the one we were living, and seeing a region being clouded by lack of information. So I thought I need to take responsibility, and I started communicating and writing a lot of things, not just scientific papers, but also trying to engage with people in their social media. I'm not very good with Instagram and Twitter. I don't understand how they work. Twitter is a little bit of a bunch of people screaming, and Instagram is a bunch of people showing off. That's what I think. While in Facebook, I can write a little bit longer, and I can express myself a little bit better. And I have contact to people in Latin America where I'm from and where my friends and family are. So I started posting a lot in Facebook and having these videos and trying to communicate. Also, quite early when countries started to go into lockdown, I was quite concerned by the fact that everybody was focusing about a lot of things like models of transmission or whether we could have a vaccination, etc. But there were some priorities that had not received any attention whatsoever. And those priorities, I called that the forgotten priorities of the pandemic. And these priorities were, in one place, misinformation. And that's the one that I was talking about. There was, just like there was a tsunami of fear, there was a tsunami of misinformation. And everybody that thought had a brilliant idea was posting it on social media, thinking that this was the solution or that this was the truth about the pandemic. And everybody became an epidemiologist, basically. And they started saying a lot of things that I didn't agree with. And I realized that it was not us the role for scientists and for us as doctors, it was not enough just to criticize what was happening, but we had to take an active role, and we needed to act as channels of communication, trying to give some sense to the evidence that is coming out, because there was also a tsunami of papers coming out. Well-being is a part that was not being looked into as well. We all got affected by the situation. There was a lot of anxiety. A lot of people had problems sleeping. A lot of people were very sad, were very worried about their families, about their jobs, about their careers, and nobody was really paying attention to this. Also, preventive measures. There was not a lot of attention being paid about what kind of preventive measures should we actually be taking. We were talking a lot about treatments when there were no treatments then yet, but there was also a lack of attention for preventive measures. And finally, the vulnerable groups. And from the vulnerable groups, my biggest concern were in the indigenous populations, and in the coming slides, we will talk a little bit about the indigenous populations, the people with low socioeconomic status, homeless people, people in prisons. I don't know if you have seen how jails look in Latin America, but they are very hacinated. They are all one on top of another, and there could be a perfect place for having a big storm. And people living with disabilities. And the problem with Latin America is that we have a very large level of inequalities, of social inequalities, of gender inequalities, of race inequalities. There is a lot of people that have a lot of money and have good access to healthcare, but this is the minority. It's also a very macho culture, so normally priority is given to men, not to women. Also, there is a lot of racism within Latin America against the indigenous populations. And this started right from the beginning of the colonization of the subcontinent. Because when the Spanish came, basically they have ranked people according to their ethnic background. So we have the Spanish people that came directly from Spain, then the Spanish people being born in Latin America. Then we have the mix of Spanish and indigenous, then the mix of Spanish and Black, and then the mix of, then they have the indigenous populations, then they have the Black people that they have brought as slaves to work in the plantations, and then they have the mix of the Indians and the Black people. So this has continued, and still today, indigenous populations have been and have suffered from discrimination. So I'll make a pause here for a second because I've been talking already for 40 minutes, but I would like to see whether anyone has any questions from everything that we have talked so far. In the next section, we're going to talk about indigenous populations. So I don't know if anyone has any question, if everyone is all right. Lara, do you have any question or comment or anything you want to ask?
No, I don't.
Okay. Willemijn van der Forst.
I also don't have a question.
Okay. I see a lot of ladies. Let's ask Tom Kremers. Any question, any comments?
No, I don't have a question.
So Tom, let me ask you a question. You have seen all of this that I just said in your lectures before?
No, this was quite new.
Okay, I'm glad that it's not a repetition. I was afraid that I was going to be telling you exactly the same you had heard before. Timmy, are you around?
Yes, I am.
How is it going? You had a coffee?
Yeah, I had.
Okay. Awake?
Awake and well.
Any question?
No, very clear until now.
Okay. Okay, guys, so let's continue talking. And the problem when we talk about indigenous population, not only they are discriminated, as I was mentioned, and they are extremely vulnerable, but also they're basically, they don't have any close contact with the government or with measurements. They are not being monitored, basically. So when Jan asked me to prepare, oh, Jan, you're still around?
I'm still there, yes.
Any questions from your side or any comments? I forgot to ask you.
No, I'm fine. It's a very clear overview.
So Jan asked me to talk about indigenous populations and COVID-19, and the problem is that there's not a lot of information. We wrote an article, it came in you're familiar with Deutsche Welle, that's the so a television or a communication channel from Germany. Quite early in beginning of March or mid of March, we wrote an article, and that's probably what Jan saw, about the fact that the indigenous populations were being left alone in the jungle without protection. That's the majority of the information that exists. So far, we haven't seen much more. So let's talk about indigenous populations and what happened. First thing is that we have a lot of indigenous populations still. There is approximately 476 million indigenous people in the world. They are all over the world, and they're approximately 6% of the global population. If we look at where they are located, we see the majority of them are in other places that is not Latin America. There are people in Greenland, in French Polynesia. This is percentages of their total population. So not in millions, so it's not quantity. So for example, we see a country like Bolivia, approximately half of Bolivia are still indigenous populations. In Guatemala, 45%. They have a lot of descendants from the Mayan culture. We see Mexico, 21%. But what happened in many places in Latin America is that the indigenous populations were exterminated. They were killed when the Spanish came, and we will talk why and how, but also they were raped. So there was a lot of mixtures. I am one of them. So I probably have blood from, I don't know how many Indians, how many Spanish, and how many Black people, and probably also have Jew blood because a lot of Jew people came to Colombia. So I am like a Colombian, typical Colombian, with all kind of colors and shades, because it's this genetic mixture that we had in Latin America. In Colombia, what we see is the amount of people that we have that are really indigenous populations is very limited, because as I said, most of them were killed to be taken their gold, or they were killed for other reasons, or they were integrated with the Spanish population and they made children, so they basically became part of the same. And we see in terms of millions in Latin America, Mexico has the biggest amount of people, of indigenous populations, then Peru, Guatemala, Bolivia, Ecuador, Brazil, Chile, Colombia, etc. As you can see here, we are talking about a reasonable amount of people. If we look at where they live, as I was mentioning, for example, in Colombia is 1.6 million people, in Venezuela 725,000, in Brazil 900,000, and you can see here the amounts of people where they live, and we have all kind of different types of indigenous populations. So we have here the Central American and Northern Andean cultures, which is here. These are normally indigenous populations that live in the mountains. They live at high altitude. They have a specific type of behaviors. They like, in particular, certain type of expressions and cultures. Then we have here the descendants of the Incas, which are basically in Peru, and then in the north of Chile. We have nomads as well. This is the Amazon plateau. Here we have the river Amazon that you can see here, starting here and going all the way here. So all of this is surrounded by a jungle, and here we have nomads. We also have still hunters and gatherers. Also here in Paraguay, in the frontier between Brazil, Paraguay, and Argentina. And basically, we have also a lot of tribes that have never been in contact with white people, or, well, civilization, or whatever you want to call it. It's simply another type of civilization. So there is a lot of indigenous populations throughout Latin America, but so far, but they have been pushed to live in very far away places. They have been pushed to live either in specific places where they are supposed to be protected, but basically they have been removed from the best lands. They have been removed from where the resources are, and they have been basically taken away from their properties and what they should have historically. So, as I said, there is 476 million indigenous people. They have a long history of devastation from epidemics that were brought by the colonizers. And you remember I mentioned in 1493 when Christopher Columbus brought some pigs that had swine flu and gave it to the Native Americans. And a lot of people died, approximately 25% of people died. But also there were smallpox and besides influenza that killed a lot of people in Latin America. This is sorry for the quality of this picture, but this is the population of Mexico. of indigenous populations in Mexico by 1520. And you can see here 22 million people. You see how there is an epidemic of smallpox and 8 million people die. And then in 1545 and 1576 came an epidemic of a disease that was called coco-lisli. Coco-lisli is not very clear what it is. It means pestilence in Nahuatl language. That's the language that they speak, the indigenous populations in Mexico. So coco-lisli means pestilence. And it's not very clear what it was. It killed approximately half of the entire population. The rest of the population, it is estimated that between 80 and 90% of the native people from America were killed during the process of colonization by violence, but mainly by diseases that were brought by the white people. So this could be things like influenza, as I mentioned, smallpox, but also syphilis was brought, and also the coco-lisli that it has been now been evaluated looking at DNA evidence. And there was a paper on Nature Ecology that suggests that maybe is something, it's more of a hemorrhagic fever, and it could be due to salmonella, which is normally transmitted through food, as you probably know. So it might have been that coco-lisli that killed so many people were caused by salmonella. What is clear is that they are extremely vulnerable. They don't have, and forgive these amounts of text, but I have to prepare these slides really fast. They have, they're very vulnerable because they are not protected. As I said, they live very close to animals. They live in very poor conditions with lack of hygiene. Also, those that are working in the informal economy. Basically, the informal economy is when you have a contract and you are not paid to have a pension or insurance. You basically just, maybe you understand black market labor or something like that. Basically, they just are given money in cash for their services. And it is estimated that approximately between 70 and 80% of these people are working in informal economy. Basically, in the moment that I don't need their or require their services anymore, they can be fired, and they are not allowed to have any compensation. Also, many of them work on tourism, and as you know, tourism was just halted. So the COVID-19 is basically a new huge threat to their health and survival, and it could be possible that many indigenous populations will be exterminated because of what is happening and what it continues to happen. They also have been seen to have high rates of communicable and non-communicable disorders, also substance abuse, alcohol intake. They tend to have life expectancies that are 20 to 30 years lower on average compared to the local population. In top of that, they tend to be with undernutrition. They have poor access to sanitation. So 70 or 80% don't have access to good water, to clean water that they can use to be able to have hygiene. They have inadequate medical services. Many of them had never had contact with a doctor. And there is also a widespread stigma against these people and discrimination. So in the time that I was working in Colombia, there was a time that I was working close to the jungle, but the jungle is enormous, is really big. And I remember one day I was in a psychiatric ward, not as a patient, as a doctor, and came a patient with a psychotic crisis. It was a lady she was around 24 years of age, and she was brought to us by their shaman, by the head of the tribe. She had come into the town for the first time ever in her life. She had never seen a car or a helicopter or things like that. And when she saw these things going around, like cars, helicopters, or things that were in that city, she went into a psychotic crisis. They don't speak Spanish, so it was very difficult to communicate with them. And the shaman came with her in this psychotic crisis, and she was managed by a colleague of mine. I was talking to the shaman while my colleague was taking care of this indigenous person. And basically, she treated her like we treat a psychotic crisis. I don't know, you had psychiatry already, or you had seen psychiatric patients, but quite often when you have a psychotic crisis, we try to sedate or try to calm down the person, and quite often a drug that is called haloperidol is given to this person to counteract the psychotic crisis. And I remember my friend put her the dosage that normally we use in patients with psychotic crisis of haloperidol. And this patient basically woke up, I think, 36 hours later, and we were quite concerned that something had happened to her. She had never been exposed to medications either. So basically, these are populations that live in very, very poor conditions. There is also a particular threat to indigenous populations that are in voluntary isolation. So these people, they are really avoiding total contact with white people. They live deep inside the jungle, and they have never seen another person, or if they have seen them, they have seen them from the distance, and they avoid contact with them. That means they have never been exposed to the diseases that affect us in a daily basis. So there are at least 78 tribes that are known that are well deep in the Amazon and have no contact with human beings. There was in the news recently an expert on an indigenous population that was killed by one of these tribes because he came too close to them. And they really are hostile because they are trying to defend themselves. They know that if they enter in contact with human beings, they probably can die. So then at the beginning of the pandemic in April 10, we saw the first death of an indigenous person being confirmed. It was in Brazil. It was a 15-year-old boy. He was living in the Yanomami community, which is approximately 120,000 people spread over in the north part of the Amazon. And he was coming and going from a city and back to the community. So this person was confirmed. He was diagnosed with COVID-19 in a hospital, then had pneumonia and died. And the fear is that this person was in contact with a lot of these indigenous populations of his community. Many of the communities, what they did is that they decided to isolate themselves further. So they decided to move away from where they were living and go even deeper into the jungle. However, the problem that we have in the Amazons is that doing mining, they're trying to extract gold or other metals illegally. So this is what is called illegal miners. Other people are cutting down the trees and selling the trunks. And other people are basically just taking down the trees, not just to sell the trunks, but also to cultivate illegal things like cocaine, marijuana, not so much these days, but it's more about the coca plant. So these people are very aggressive, and they can come in contact with the indigenous population. I don't know if you see, you all have Netflix. So there is a nice series called The Green Frontier, which was filmed within the Amazon region, and it's very interesting. If you want to see it and see a little bit how things look like, The Green Frontier is a good series. I'm not trying to promote anything here, but in case you are interested. Very important is that the indigenous elderly population are the ones that are among the most at risk within the population. And why are they so important? Well, first thing, we've seen that COVID-19 affect at a higher risk people that are elderly. And second, because these cultures, some of them don't write. So the tradition is oral tradition. So their knowledge, their culture, the language is passed down from generation to generation. So the elderly are very important for their communities because they are the ones that hold the largest number of knowledge, of information, and history that is being transmitted to the newer generations. If a pandemic such as COVID-19 affects this indigenous population and kills this elderly population, it's like they basically stole your iPhone. Basically, they remove all the memory from your culture. Also, indigenous women are at particular risk. What we see is women are quite vulnerable because they can be subject to violence because they are the ones who are working even more in informal economy. Normally they work as cleaning ladies or they work in restaurants and they are not paid properly, they are not treated properly, not even by their husbands. And we have seen a huge amount of increase in violence against women, not just in the indigenous population, but throughout the world. So there are some recommendations that the United Nations try to share. You know how this goes. They give the recommendations, but nothing is really being done. In fact, when I look for papers or for more information besides the article that I mentioned that we wrote with the German channel, that what I found was basically this is the only article from a newspaper, from ABC News, which is trying to focus on trying to dig a little bit more information about what's happening. And I think they did a good job. They talk, for example, how there is a huge amount of cases happening in this time. This was by June. So the pandemic had moved. The epicenter was then in Latin America. We saw communities like the Paracuro community in Peru, where approximately 80% of the population was being infected. And we saw also behaviors from presidents in the region, which basically say that there is not a problem, that the indigenous are fine, that they are just hiding in the jungle. But basically, what we are seeing is that the fires in the Amazon had started again. And these fires are not in the majority natural fires. They are provoked fires in order to deforest, in order to start plantations, mostly of illegal things. So just to show you a little bit, again, this is the Amazon River, starts here in Peru, and it goes through Colombia, then it goes into Brazil, and it ends here. And this is the Amazon jungle. And here is the city of Manaus. And you probably, if you like football, you heard of Manaus because there were games in the time of the World Cup when it was in Brazil. But Manaus was the center is the capital of the Amazon region of Brazil. And after the epidemic came to Sao Paulo, it then moved away to different parts of Brazil. And then Manaus was the city that was hit the hardest. In fact, there is this paper, it's a preprint, it was published yesterday, that has shown that approximately, and just focus on this square, you can say here, approximately the amount of people that have been having or that have had antibodies against the virus. By May, there were approximately 45% of the population in this city of Manaus, and by August, 66%. So it is possible that Manaus was the first city in the world to have reached population immunity or herd immunity. You probably heard about it, and I will tell you maybe a little bit about it later, what is herd immunity and what it means. But basically, if a proportion of a population is infected, that protects the rest of the population by cutting down the chain of contagion. And we think that approximately 60 or 70% could be a number. Some people say maybe it's lower, maybe we just need 20% of the population being infected. But so far, we think it's around 60%. And Manaus has reached this in around August. So this is the situation and how has been happening since. What we are seeing right now, this is data from the September 21st. I think today is 22. I don't remember what day is today. But anyway, you can see here how the pandemic started being a problem of Asia, then it became a problem of Europe, then of US, then it came South America, and you can see here how South America has surpassed in terms of the impact on the pandemic. In terms, this is daily cases per million people. So taking into account the amount of people that are available. And this is a little bit just for you to see how the pandemic has been happening in 3 of the countries with the highest concentration of indigenous population and presence in the Amazon plateau. So Peru, Brazil, and Colombia. You can see here Peru, which is the country right now with the highest number of deaths per million people. We see Brazil, we see Colombia, and here you can see this is what happened before when everybody was scared and were applauding doctors. And here is what's happening now, which is not very good for the Netherlands. This is a little bit of the situation in the world. You can see the the top countries being affected. You can see countries like Brazil, Peru, Colombia, Mexico, and Argentina among the top 10 countries most affected in the world. So it's really hitting Latin America. And when we see, where we see the biggest increases in the last week is in Paraguay, Costa Rica, Argentina, Czech Republic, and Israel. The Netherlands is below. You cannot see it in this. So in the next part of the lecture, and it's 11:11, so we had some time, I wanted to talk to you about things like the second wave. Does climate play a role? What is the situation with treatment? What are the next steps, etc.? Is there any questions until now? Kevin Nguyen. Are you with us, Kevin? Kevin? Kimia Gambari.
I have a question. Can we have a quick break?
Yeah, sure. How much time do you need, Kimia?
5 minutes or 10?
Yeah, take your time. So we'll start again at 11:20. Is that fair?
Yeah, thank you.
Okay, thanks. Jan, are you still here?
Yes, I'm still there.
How are things? Everything okay?
Yeah, it's very nice to have this insight in these populations in South America, which is really, yeah, how do you say, intriguing. So I read.
It's more sad than intriguing. I think it's just what happened. There is a catastrophe.
Yeah. So
but you were saying
Epidemics and Society from Frank Snowden, and we had Frank Snowden from Yale for a masterclass a couple of weeks ago in the program. And also that, so this is of course not about indigenous populations so much, but more about society's response to all kinds of pandemics, epidemics since the Middle Ages, since the Black Death. And what I told the students as well, and what Frank Snowden also told them, is that what we do now for quarantine and isolating patients and etc. is not that different from what they did in the Middle Ages. So
I lost you, Jan, or you're still there?
no, so that there is not so much different what we do in quarantining, isolating patients than what we did in the 14th century in the Middle Ages with the Black Death.
Yes, but you know what is even worse is not only that we are doing exactly the same that we used to do, but we are repeating the same mistakes as well. We know very well what worked and what didn't work in the time of Spanish flu and in the previous pandemics, and we still repeat the same mistakes. And we still keep on insisting in being a skeptic and doing the same that we did before.
No. Yeah, so it's learning by doing also this pandemic.
Yeah. So Jan, I see there are questions from Nadine and from Michael, but I don't see the chat when I'm presenting. So if you could help me keep track of the chat, and then when we start again, I'll start with the questions from Nadine and Michael. But if you can help me, please keep track of the chat. Then if you see a question, please let me know. I just don't get to see it while I'm presenting.
Yeah, that's okay. So these were the first two questions, really. There was one remark by Jajo. I'm not sure who that one is.
Yeah.
But who really? I think you were talking about fake news and all these social media outlets. And then, of course, yesterday you had this hashtag "Ik doe niet meer mee" by these social media gurus in the Netherlands. People who think.
What does it mean? I know what it means in Dutch, but what does it mean? I mean, why are they doing it?
So you heard of Willem? I'm not sure what his back name is. So you heard of Virus Waarheid?
No, I only know football players in the Netherlands. I don't know politicians or anything else. And I know Julian.
That's Willem Engel. So he's he did biopharmaceutical sciences in Leiden a long time ago, and then he went to be a dancer and a dance teacher. So he for the rest of his life, he was never involved in science anymore. He has a lot of critique about the measurements and about corona, and that it's all exaggerated, etc. So he has a movement now which is called Virus Truth or Virus Madness. And he arranged that some of the influential social media people in Holland sent messages yesterday with hashtag Ik doe niet meer mee, I'm not along anymore. And then they end with free the people. So it's like they're suggesting that we are living in under a dictatorship by the government and a dictatorship of corona. Which is and so some of these people, they were involved in having young children know what to do with corona. So they were hired by the government to have students and young children act how they should be. So do social distancing, etc. And now two of them do exactly the opposite. So they were paid by the government to have a positive message about corona measures, and now they do this hashtag about corona measures is really wrong, and a dictatorship of corona measures and a dictatorship of this government, etc. It's really
very difficult topic. Yeah.
I think they should have a look into the hospital and get corona themselves, but
that's quite cruel. But just to finish before I go and get water, but there was this story of this priest.
But Claudia de Breij, so you know Claudia de Breij? She's a Dutch cabaretier, and she, as a reaction to this hashtag, she said, "Okay, so if you do like this, then are you okay if doctors also say if you present yourself to the emergency room to be admitted with COVID, that they say, ik doe niet meer mee." So that doctors will say that if you do this, that doctors won't admit you to the hospital because you're part of this movement, so to say.
Fair enough. I think doctors have been extremely mistreated. We just published a paper in American Journal of Epi, looking at the levels of infection among healthcare workers. We found around 11 to 12% all around the world. We had 279,000 healthcare workers. And what is also scary is that when 40% did not have symptoms when they tested positive. So there could be transmission within their colleagues and patients. And normally it came within the healthcare facility, not within the community. So they actually spreaders to community. It's just it's a pity because they don't have to get infected. They can be protected with adequate equipment. Jan, I'm gonna go and get water. I'll be back so that we can start in 1 minute.
Yeah.
11:20. Is everyone back? So welcome back from your break. I'll start answering some questions. I don't see the chat when I'm presenting. So whenever you have a question, don't be shy. You want to interrupt me, you just open your microphone or just say it, and then I'll stop. Don't worry about it. So we have still 40 minutes. Of course, you are not obliged to stay in the lecture, and you're not obliged to stay in the discussion, but I'll be happy to talk to all of you. We'll start with a question from Nadine Lowe's. I have a question. How did the indigenous people hear of the coronavirus or got infected? So they, since they are in voluntary isolation, you said before that these groups are extremely violent against outsiders. Yes, they try to protect themselves. It's not all of them. So there are a small percentage of the indigenous populations in the Amazons that are in total isolation from the rest of the world. Normally, those that are in total isolation, they probably haven't heard about the virus. But there are other communities that are nearby. For example, the Yanomami, as we explained with, as I mentioned, that kid, age 15 years of age, that died on the 21st of April, he was working in the city. So he will go into the city and come back to his community. So many of them had certain contact with the cities by visiting the cities. Or some of them, they speak in the jungle with those illegal miners or the people that are there that are doing trade or drug dealers that are producing cocaine, etc. So some of them had contact with the outsiders, and they heard that something was coming, and they got really scared. That's why they packed their bags and they moved deeper into the jungle. Why did the Spanish flu come in waves? And then why did the second wave kill the most people? As Michael. So Michael, I see you there. So Michael, the first wave was quite focused. I cannot hear you, you're talking, but because your microphone is muted. But I don't know if you can hear me. But so the waves of the Spanish flu, the influenza responds to atmospheric conditions. So we've seen that influenza has these waves. Also, the normal endemic influenza that goes every year, it has periods of time normally when it's rainy, when it's fall, when it's winter, when it comes and hits harder. Coronavirus is not showing any response to atmospheric conditions, but influenza does. The second wave affected a lot of low and middle income countries. So a lot of people died in India and in Latin America. And these were soldiers that were moving back to their homes. There was the First World War finished by the end of 1918. And a lot of soldiers started, when the armistice happened, started to move back to their homes. So they went around the world spreading the disease. And also there was a lot of trade. So the virus followed the trade. There was a lot of things that were going from Europe to America, from America back to Europe, or from Asia. And those trade lines were followed. So it came to the southern part of Asia, as I mentioned, India, Latin America, etc. And it happened in waves because of that, because it responded to the movement of the population, but also because the waves of the influenza are quite determined by the atmospheric conditions. And it killed most people because it hit the first. So normally when a virus comes, it hits the first and it kills those that are closer to being affected. We have a question from Britt Berkers. Thanks, Michael. How is healthcare on COVID-19 in South America? Are people receiving the care they need? No, Britt, I think they don't. I think they are actually being very poorly treated. They are doing all kind of weird things. So some of them are drinking something similar to chloros or detox. So they have this called chloride dioxide, I think. I don't know if you have heard of that. You probably heard an interview that Donald Trump said that you probably should drink some disinfectant. You've probably seen those products. Well, in Latin America, they are drinking it. So a lot of people are actually taking it in lower dosages, and they say that this is the cure for everything. And this is thanks to a guy from Switzerland that married a Peruvian woman, and he can speak Spanish. And because he's blonde and he looks fantastic, everybody believes everything he says. So now everyone is taking this chloride dioxide. That's the problem in medicine, that there are things that sell far more than evidence. Also, they are taking a lot of ivermectin. You probably heard of ivermectin. Ivermectin is an antiparasitary drug. doesn't produce a lot of side effects. It's quite very much used in animals. And there was a paper from an Australian group that the title was FDA approved ivermectin seems to kill coronavirus, something like that. They were referring to ivermectin being approved by the FDA for another type of conditions, not for coronavirus, but people in Latin America don't speak English. So they read FDA approved ivermectin against coronavirus, and they started to give ivermectin to absolutely everyone. So the care in South America is really poor. There is a few people that have money and they have access to healthcare. The majority of people do not have access to healthcare. Leonard, in the concept of herd immunity, is the concept of herd immunity seen in Manaus? Yes. So after they had tons of people dying, and I can show you a picture while we talk. So while they have tons of people dying in Manaus, there was an incredible amount of people that die in Manaus. I'm gonna put the picture in a second. While a lot of people die in Manaus, they seem to have now reached herd immunity. And what we are seeing in Manaus is an unexplained amount of reduction in the, I'm gonna put you this picture, amount of reduction in number of people infected. Okay, share screen. This is how they were being buried. You can see it, right? Okay. So yes, there was herd immunity, but what I say is this is the kind of pictures you're gonna get if you go for herd immunity. This is the risk you run. Maybe it won't be the same in Sweden. If Sweden goes for herd immunity, maybe it's not the same. I don't know whether you guys know a lot of Latin American people, but we tend to be very close to each other. We hug a lot, we touch a lot, we come close to people in their faces. So for us, it's very difficult to keep distance. They say that in Sweden, people are asking when are they gonna go back to their 6 meters distance that they can keep from each other. This is a joke, don't take it seriously. But in Latin America, we are very close to each other, we hug a lot. So for us, it's very difficult to go for herd immunity. Saying those social distancing to a Latin American is almost impossible. So they find it very difficult. As it's seen, the question of achieving herd immunity, the question of offering about 3% of your population to this virus. Could you say something about this? Yeah, so there will be a lot of people that will die if you go for herd immunity. We know that mortality is around 1%. So you can calculate 16 million people that live in the Netherlands, calculate 1% how many people will die. So herd immunity is like playing with fire. It's like playing with fire and trying to start a fire in a forest and trying to keep it controlled. It's very difficult to control a fire. What are your views on the coronavirus policies in Brazil? Terrible. So Bolsonaro is a skeptic. He follows the line of the government of Trump, and Bolsonaro basically has said all the time that the COVID-19 is just a flu, it's just a gripezinha. That's how they say in Portuguese. And gripezinha basically means a little flu. There is nothing to be worried. He had coronavirus like a month ago. He recovered, then he got some complication, but he's fine. He never put a face mask. So the policy in Brazil has been basically not to implement any measures, and but it's a federal state. So you have the states of Rio de Janeiro, Sao Paulo, etc. I don't remember the names of the states, Paraná, where Curitiba is. So the governors of each state, they decided to do their own policy, so they had lockdown or not. And however, the president was quite outspoken that he was against any measures against a small flu, and we couldn't kill the economy because of that. And that's what explains why Brazil has so many cases. In top of everything, if you look at the number of tests, the proportion of tests per population, Brazil is one of the countries that is doing the less tests. So you probably have 10 times or 20 times the amount of cases that you see in the numbers in Brazil. So if it says that it has 4 million, probably they have 40 million people infected, and I'm not exaggerating. So the situation in Brazil is just not good at all. How does the healthcare system work in Colombia? The healthcare system in Colombia, they have tried to move towards universal healthcare where everybody has access, and the health system collapsed. Of course, there was not enough money, and a lot of people took their cut. That happens a lot in Latin America. There is a lot of corruption. So the healthcare system does not work well. The GPs do not exist. There is a type of GP that was being implemented that is called family doctor. They train for 3 years, but they are more the exception than the rule. Normally, the patients go directly to general doctors. So you just finish your bachelor, you do a practice. Normally it takes 6 years to train in medicine in Colombia, then you do 1 year practice, and then you're ready to see patients. That's not the case in the Netherlands. So these people, they can treat whatever they want. Normally they go to the emergency room, and in the emergency room, they give it to everyone, and it's a total mess. It's been very difficult because I've been quite vocal about the situation in Colombia, and they have been quite vocal against the fact that I've been quite vocal, if you know what I mean. So I had a lot of weird communications, a lot of weird threats, and a lot of attempts to censor what I was trying to communicate in the social media. But I'm still around, and I'm not in Colombia, and I hope they don't come here to Leiden. Don't tell them I'm in Leiden. Doesn't it seem like a long time from December until February before the first person died? You mean in China? They had to do anything with virus involvement, or is that because virus is not very deadly with healthy people are infected? So Nina, I don't know, because there's a lot of skepticism about the data in China and how much they reject, they really recorded the cases and the deaths. So this has to be investigated. But the mortality of the virus, what we are seeing all over the world, is very similar. It's around 1%. So it's not going to kill a lot of people, but it's going to send 20% to a hospital. And what is worse, or what we should be worried about, is that we are seeing that around 2/3 of people that have had COVID-19 have long-term sequela. They had either chronic fatigue, or they have headaches, or they have vertigo. They also complain about gastrointestinal symptoms, anosmia. You probably heard of anosmia, that you cannot smell. You think that's nothing, but then everything you eat doesn't taste nice. So it's a virus that is not as mild. It's not a gripezinha like Bolsonaro says. It's not just a small flu. Guys, we're going to continue with the lecture if you don't mind. So I'll share the screen, and we're going to see in the next 15-20 minutes, we are going to talk about the next steps of this virus and what is going to happen. So will there be a second wave? What happens with hot climate? That is a question that I get all the time, and I answered it with one slide. This is Iran. And basically in Iran, what we see here, the new year in Iran is Nowruz. It happens on the 20th of March. As you can see here, a lot of people gathering, and here the explosion of number of contagions. Iran goes into closure. They reopened when things were going down, but still they were having more than 1,500 cases per day. So what happened? Here you go, boom, it goes back up. Now they have new measures, it's going down, but now they're talking about a third wave that probably is starting to increase in the last weeks in Iran again. What we see also is that this increase here was happening when the average temperature in Tehran was 37 degrees. So this theory that when it hits hot weather is not going to transmit or is not going to affect people is just rubbish. So there is such situation. Second wave, is there a second wave in Europe? You can see the numbers. You can see Spain here, France, the Netherlands, United Kingdom. We have 2,300 and something cases yesterday in Holland. I don't remember, you know better, but you can see here, this is the peak in September 21, number of cases per day, approximately. This is per million people. And you can see here when we had the whole situation in March. So it's higher. I know there is doing a lot of more tests, and a lot of more people are accessing this test. I don't know how long that's going to take, because the system is already starting to exhaust. And I think they're going to run out of tests because they didn't prepare themselves sufficiently. They have plenty of time to prepare, right? They have all these months. And now they say we don't have enough tests. So has the virus mutated? That's another question that I get all the time. All viruses mutate. That's normal. They change. Influenza mutates quite fast, mutates quite often. This coronavirus approximately has a major mutation twice per month. That's what people think. And what we are seeing is that the original version of the virus, let's put it that way, that was called D614. That was the one that caused the epidemic in China. There was a new type detected on February 20 that had already a combination of 4 mutations. A previous version of the same had 3 mutations, was detected in Wuhan. This one with the 4 mutations was detected in the north of Italy. And you can see here how this new version, the G614, went to basically remove and replace the old version of the virus and basically became the pandemic. So we see a new version of the virus being there. Normally in evolutionary terms, these mutations will tend to favor increased infectivity, and that's what we are seeing. So the new version is, they say, 3 to 9 times more infectious than the previous version. And it tends to decrease lethality, but this is not what we are seeing. There are 2 studies that compare lethality of the 2 versions of mortality. And this was in the UK and the US, and they found very similar severity and very similar levels of mortality. So it seems that these mutations are favoring the infectivity rate, but have not favored a decrease in mortality. And why do they want to decrease mortality, the viruses? They want to decrease mortality because they don't want to kill their vehicles, and the vehicles is us. So I'll continue. If there are any questions, please tell me. In terms of next steps, we see here how it's been happening in Spain. They had what was called la desescalada del coronavirus. That happened, you can see here, the curve of Spain started to happen around here at the end of April, when they still have 1,000 cases per day. And it also happened in Switzerland, very similar stages. It was approximately 2 weeks per stage. And you can see here how in Switzerland we came close to almost none. In Spain, they never reached lower than 300 or 400 cases per day. And what we saw in Spain is that because tourism is so important, they started to invite all the English, all the Dutch, all the Germans to please come to Spain and visit us. Please come and do tourism. And what we saw is that basically Spain closed the group of experts that were advising them, and they just went on with a number of measures that had no sense, no clarity. They reduced the amount of tests, they reduced the amount of traces. And what we see now, Nina, I will answer your question in a second. So what we're seeing now is that Spain is going deep into a second wave I showed you in the previous slide. Nina has a question about immunization and antibodies per mutation. So a lot of people have been working on the vaccines, and there is a fear that they have been working with the previous version, with the D614, and it's not clear whether this is going to have an impact in the development of immunization. But what is clear is that people that are working on these vaccines have been informed about this particular collection of mutations that are occurring in the protein, in the spike protein, that is that thing that the virus used to hook to the cell and to go in. So I hope and I think that they are going to be taking into account this new variant. So let's talk about long-term solutions. Let's talk about immunity, vaccination, treatment, and non-pharmacological measures. We have 20 minutes left. First thing is that the only way that we can solve this is through immunity, to group immunity, or through cross-immunity. I don't know if you have heard of cross-immunity, but basically, let's talk about herd immunity first. Herd immunity, as I mentioned, is when an amount of the population, sufficiently big amount of population, is infected, then the chain of contagion stops. And what we are seeing in the big cities that were affected, in New York, for example, there was up to 20% people having antibodies. In Wuhan, 10%, Boston, 10%, Barcelona, 7%. And one of the biggest seroprevalence studies that were done in Spain, in the entire country, they found that in the entire country of Spain, that was one of the countries most affected, the seroprevalence was around 5%, which is very low compared to what we were expecting. In Stockholm, where they didn't have measures, is approximately 7%. Now, what we're seeing, if you know our immunity, which you know, there are different types of acquired immunity. You have the the humoral and the cellular immunity. Humoral immunity with the antibodies, and the cellular immunity by T lymphocytes. And it is possible that the response, and this is a paper that came out from Karolinska, I think I have it here. Yeah, here. From Karolinska suggests that there is perhaps double the amount of people that are that have a certain type of protection against this coronavirus through the cellular immunity, not just through antibodies. But so far, measuring T cells is very difficult. So what we are seeing in zero prevalence studies is measure of antibodies. Then came a paper which is, I think, a light of hope, which is about cross immunity. And cross immunity is basically, we have, this is not the only one type of coronavirus circulating. We have 4 types of coronavirus that are endemic that produce the common cold. And every year they come and they produce the common cold. And people have been exposed to that type of coronavirus. So there was this paper in Cell, and then a number of papers that came afterwards that suggested that people that have been exposed to this endemic coronavirus that produce the common cold could have a better defense against this new coronavirus, because they are approximately between 40 and 60% similar in terms of the structure. So cross immunity refers that when this cousin or the brother of the endemic coronavirus comes and affects you, you have been exposed to the previous one, you will defend yourself better. And this could explain why some people get severe COVID-19 and some people get mild or no symptoms. And this could explain as well why children are having better protection. This is one of the theories. Another theory is presence of receptors for the virus in the nose and in the lungs and the respiratory airways. But cross immunity could be a hope in the sense that also people living in slums or people living in under close density could have been more exposed to this previous coronavirus that caused the endemic type of coronavirus that caused the common cold, and they could be better protected against the new coronavirus. That's something that we need to clarify, and this could be a shortcut towards herd immunity, because herd immunity can only be achieved either by infection or by vaccination. And we're going to talk about very briefly about vaccinations. We have normally on average 10 years to develop a vaccine against a disease. There are diseases that still don't have a vaccination. And what we are seeing is right now, this is from yesterday, and I know September 18, there is a coronavirus vaccine tracker that is very nice and easy to read. It's in the New York Times. You can easily Google it. And normally it shows you the different vaccines that are being developed. We see so far 0 vaccines approved for full use, but we have some vaccines that have been approved for use in the military services in China. And in Russia, you heard when Putin, the 11th of August, announced a Sputnik 5, which still is under phase 3 of evaluation. The good thing is we have a number of vaccines, 9 vaccines that are being evaluated on phase 3. I don't have a lot of time to talk about the different phases of evaluation of the vaccine, but phase 3 is when you look at thousands of people, the effect of the vaccination and whether it has any impact in terms of adverse effects. And you probably heard about the vaccine of Oxford and AstraZeneca that has been the one most promoted, that was stopped because there was a patient that had a severe effect from the vaccine, and it was being studied. It was then declared that it was going to recommend, and 2 days ago was stopped again because there were new cases, and it's still not very clear whether and when they can continue with this evaluation of phase 3 of the Oxford AstraZeneca vaccination. I move forward so that I don't keep you forever here. In terms of treatment, a lot has been said, but what is most important is to test, trace, and isolate. This we have been saying it all over the pandemic. The WHO has said it, and still we come up countries that are supposed to be serious saying that they don't have enough tests. We saw probably in the news, the entire test system in the UK collapsed in the last 2-3 days, and they have been waiting and waiting to fix it. Just to show you, I don't know why we don't learn from our own mistakes. For the rest, in terms of treatment, for antiviral treatments, there has been a lot said about remdesivir. It seems to reduce the amount of duration of the infection. It's not a cure, and the data is still not that robust. The same goes for favipiravir, that It was being produced by Toyama Chemical. This is from the Fuji house in Japan. Then it became generic by the end of 2019. So the Russians started to produce it, and they have been selling it to all countries in Latin America. The name of the commercial favipiravir in Latin America is Bifavir. That's what is being produced by the Russians. So basically what we're seeing is drugs that do not really seem to work or have a small effect, but they have become a commercial success or a commercial target for the powerful to exploit the poorer. You heard about dexamethasone that seems to work only in patients with the severe COVID-19 when they have already respiratory assistance with the ventilator or with oxygen being administered. It's not very clear whether in that case there has an effect, but they haven't found an effect in less severe cases. We have another anti-inflammatories, to call it like that. They're normally used for rheumatoid arthritis, Actemra, tocilizumab, and anakinra, which is called Kineret. They block the interleukin-6 receptor for Actemra and the number 1 for Kineret. They had shown that they seem to have some effect, but the last RCTs that are coming out are not very promising. You heard a lot about convalescent plasma. Hydroxychloroquine still is a discussion, despite that all evidence is showing that hydroxychloroquine has no effect. But you know that Trump and Bolsonaro have been promoting hydroxychloroquine, and this has become basically a political and a business issue rather than a scientific issue. And scientists are basically being told to shut up. Then there was a suggestion of fenofibrate, because it seems that fat is a substrate that the virus uses, and fenofibrate could help. This is very early stages. And there was a lot said about ibuprofen. Early in the pandemic, they said, do not prescribe ibuprofen. This was the French government. Ibuprofen is dangerous. Then they said, no, maybe it's good. And now it's being studied. There are RCTs to evaluate whether ibuprofen works. And then I told you about ivermectin, that is normally used as an antiparasitary, and that's basically it. There is no treatment yet found that actually works, and we are still, what we are trying to find is repurposing existing drugs, because developing a new drug will take 10, 15 years. It's just like developing a new vaccine. It takes a lot of time and a lot of steps. So what pharmaceutical companies are trying to find in their portfolio of drugs, see what kind of thing works, and then try to evaluate whether they actually have an effect. Also, there is a lot of theories about the bradykinin and using drugs that attack the bradykinin as a potential mechanism for this. It's not very clear whether it's going to work also. We are very early. While we get a vaccine, while we reach immunity, and while we get treatment, we need non-pharmacological measures. And these non-pharmacological measures is basically the same things that we were doing 100 years ago. This is a paper we published recently, where we try to look at how to use dynamic measures of restrictions and liberations according to the transmission of the virus, in order to keep the healthcare system not from collapsing. This has been called in Latin America, we play accordion from, it comes from Germany, but we play it in salsa and all that stuff. So it is called the accordion measures, because as you can see, you close and open, and it looks like an accordion. But at the end, what we are gonna have to do is get used to live with the virus while the vaccine comes or better treatment come, because at the same time, while we are trying to keep everyone at home, we know that the economy is important, that psychological effects are having a big consequence in people of suffering from lockdowns. And I think we're gonna have to have this combination of dynamic measures. For low and middle income countries, we published also this paper where we basically were suggesting to have zonal lockdowns, in which particular regions are under cordon sanitaires, and also rolling lockdowns, basically these dynamic measures. And now that's what we are seeing. That's probably where we are going to. There's going to be zonal lockdowns and combinations of rolling lockdowns and restrictions that are going to be happening in the next year or year and a half, until the vaccination becomes available or until the solution is found. So I hope this is going to be soon the end of the pandemic. I think one thing we have learned is right now the entire world is restricted. We are not living the normal lives. We should have been in a classroom. We should be talking to each other, but we are here through this nonsense of camera. I never like cameras, but this is how we have to talk. And I hope in the future we realize that ultimately the pandemic is a symptom of a sickness rather than a sickness per se. And what I mean is planetary health is the key issue. This pandemic is occurring because we are invading and destroying ecosystems. We are invading other species. We are not taking care of the planet. And unless we take care of the planet, we are not going to be able to see an end to the number of pandemics that are going to be coming in the future by being every time more in contact with locations, with species, and with viruses that we shouldn't be in contact with. Also, one thing that I think the pandemic has taught us is that we are all extremely connected. Just as the virus is happening in China, can actually happen in Italy, can happen everywhere in the world, can happen in Latin America. We are very closely connected, and we need to keep that in mind. This situation is not going to be solved until the virus is solved all around the world. Otherwise, it's going to come back. So this is the end of the presentation, and I leave you with the picture. This is the institute that I lead, the Institute of Social and Preventive Medicine in Bern. And this is a picture of Bern. The river is nice. You can jump in the river and swim. Don't kill yourselves if you cannot swim. It can be strong currents. It's a nice city. If you ever come to Switzerland, please drop me a line. You're always welcome. So this is the end of the presentation. We have some time for questions if there are questions, and I'm sorry that I spoke so long.
Thank you very much, Oscar, for this wonderful presentation. So, are there questions?
I have a question. Where you talked about the indigenous people and how they suffer the most, or at least they suffer from the coronavirus. But do you think there is a way to help them to reduce the suffering, and how can there be better data about how they about the cases of coronavirus?
Thanks, Chris. I think having better data from them is not going to be on time. When we try to establish the mechanism to get the data for this pandemic, either they are dead or the vaccine is around or the pandemic is over. I think we are too late. I think we need to keep this in mind for future pandemics in terms of what we can learn and what needs to be put into place for in the future that we don't have the same situation. And right now what we're seeing is that the fires in the Amazons restarted. We saw a lot of fires in the Amazon at the end of last year. Now they have restarted, and these are not accidents. They are happening because they are burning land to be able to make it into cultivated areas. So nobody's saying anything. And Bolsonaro is doing whatever he wants. The governments in South America are doing whatever they want, and nobody's saying anything because nobody seems to care. I don't know how to help indigenous populations myself. What I'm trying to do is try to be a voice and try to share information and try to write articles about it, try to talk to my fellow Colombians and fellow Latin Americans that these people need help and that we just cannot ignore it. But there is a lot of stigma and discrimination against them, and a lot of people really don't care or couldn't care less about them. They are seen as not important people in the society, unfortunately. So I don't know if there is more questions or comments. Don't be shy, or if you are tired, feel free to leave, don't worry. Thank you, Valerie. Thank you, Kimia. Thanks for the messages. Thanks, Iris, Jale, everyone. If you want, I post a lot of things on Facebook. Normally they're posting in Spanish, but you can read them if you translate them. I never published before in Spanish. Of the 700 papers or so that I had published were all in English. But during this period of time, I had been publishing not only papers, not only posts in Facebook, or sometimes in Twitter, which I don't like, but I try to also write articles that are written in Spanish because unfortunately in Latin America, people don't know English. It's just as simple as that. We are happy and we are nice, but we don't speak English. I learned English in Australia. But in Colombia, people don't speak English, so they don't read. And what they read is a lot of crap. So that's why we try to provide, I try to translate things or papers that come in cell that are impossible to be understood even by medical doctors. I try to translate them in common words so that the normal person that is walking around can understand what it means mutation and or what it means treatment or what means immunity by T cells and cross immunity, which is very complicated concepts for the normal people. So I'm trying to do that. If you want to help, just be a voice. Just be careful yourselves and take care of your family members that are the ones that are going to get really, really ill. Not you. You're young. You're fine. Any other questions?
I have still one question because you spoke about the herd immunity, but when there are mutations of the virus and there are also people who are getting the virus more than once, is there a possibility to reach herd immunity?
Well, excellent question, Anouk, because herd immunity was very much in the political agenda in the UK. It was in the Netherlands, and it is in Sweden. And still, they're talking about herd immunity, despite that we're seeing everything that we have seen. In Manaus, you saw they probably reached herd immunity. 66% of the people were infected. A lot of people died. It was a total massacre. A lot of indigenous people died. A lot of poor people died. So they reached herd immunity through a big price. And the problem that we have is we do not understand the immunity yet against this virus. So it's possible that the herd immunity will last for a number of months. We're already seeing that the number of antibodies start decreasing with time. With the previous SARS virus, we saw that it lasted on average 18 months to 2 years, with some people having immunity only for 6 months. So what it means is even if you reach herd immunity in August, it is possible that by December, you lost herd immunity just because of the nature of the immune system. That is on one hand. Now you add one more thing. What happens if the virus mutates so differently that then the virus, the immune system of our body doesn't recognize it and again gets infected? There's been some cases of reinfection that have been reported also in the Netherlands, in Belgium, in Hong Kong, etc. That could happen. But we're seeing so far, and that was in the publication itself, is that these T cells react to the two variants. So there could be cross immunity. So that if you have had one of the variants, you will be protected from the other so far. But what is going to happen in the evolution of the virus, and where we're going to see a new virus or a new variant of the virus replacing the existing variant, the G614, we don't know. So that could happen in the future as well, and that will be very tricky. We see with the influenza, for example, that mutates more often, that every year we need to change the vaccination or what we put in the vaccine for influenza. And that could happen in the future with coronavirus if it becomes endemic. So thanks a lot, Anouk. Excellent question. All your questions are excellent, not just Anouk. Sorry. Also yours, Chris and Michael. All the questions are fantastic. Yeah. So any other questions, comments?
I see a lot of thank yous in the chat, Oscar. So
No, thanks everyone for listening and trying to understand my Spanglish. So.
Yeah, you get used to that. No, thank you very much for giving the lecture and for being so flexible to do this earlier today instead of next week. I enjoyed it a lot, so I hope the students did as well. And perhaps there will be some students who will go to Cuba, Colombia, or Ecuador, or Brazil, who would be willing to join you in your efforts to get local language papers on and with information for this COVID corona epidemic. So it would be nice to do.
I hope you all go. It's a nice place to go. People are friendly, good weather, wonderful food. What am I doing here? Yes, I know. I'm mad. I should be there. That's life.
Yeah, I know. I've been there. Enjoyed it a lot. So
yes.
Okay, call it a day then.
Okay, thanks everyone, and take care of yourselves. And if you want to go or you want to hear more about Colombia, don't be shy. Drop me a line. You can find me my email, or Jan has it, or I write it here to everyone. And don't be shy if you want to talk about anything, or if you want to work on write papers. That's what we do every day. We do research and we do communication. So that's my email. Take care of yourselves, and whenever you want to drop in Leiden, I'm here as well. So see you guys. Have a nice time.
Thank you very much, Oscar.
Thanks.
Okay.